Bougie-assisted Crike. My name is Afshin Khazi. I'm an emergency physician, and we are here today at the Center of Excellence for Simulation Education and Innovation at Vancouver General Hospital. There are a number of different options for obtaining a surgical airway. In most cases, Bougie-assisted Crike is the best option. If you can anticipate the need for a surgical airway, you should prepare by doing a double setup, which is described elsewhere in the course materials. Ensure you are protected with a face shield, gloves, and a gown. Lay out just the instruments that you will need in the order that you're going to use them. This avoids having to rummage through a pile of unnecessary instruments while the patient is desaturating. This also serves as a final check that all equipment is available. Scalpel, Bougie, number 6 endotracheal tube, syringe, end-tidal CO2 detector and bag valve. Some lubricant is also helpful. Begin just above the sternum in the sternal notch and palpate cephalad until you feel the first prominent structure, the cricoid ring. The cricothyroid membrane is the depression just cephalad to the cricoid ring. Just above is the laryngeal cartilage. Once you have found the membrane, stabilize the larynx with the first and third digits of the non-dominant hand, allowing your index finger to rest on the membrane. We call this the grip of death, and it is critical that you maintain this grip throughout the procedure until your index finger has been replaced by an instrument or a tube. If there's a lot of soft tissue in the neck, it may be difficult to feel these structures. In these cases, estimate the approximate location of the membrane and make a generous vertical incision centered on that spot. As you cut deeper and deeper, repeatedly palpate until you can confidently feel the desired landmarks. So I'm now making a vertical incision centered on the cricothyroid membrane. And if there's a lot of tissue to go through, I'm cutting deeper and deeper until I can confidently feel the cricothyroid membrane. I'm now making a horizontal incision through the cricothyroid membrane. Having made a horizontal incision through the membrane, I immediately replaced my index finger in the hole. At this point, you may see air bubbles come out of the hole, and if the patient is receiving positive pressure ventilation, you may receive a dramatic spray of blood. This is why it is necessary to fully protect yourself with a face shield and ask that ventilation attempts be held as you cut into the membrane. Using the tip of your index finger, guide the curved tip of the bougie through the membrane and down into the trachea. You may feel some intermittent resistance as the tip of the bougie rubs against tracheal rings. If there's a lot of neck tissue to go through, it is possible for the bougie to miss the airway and go along a false passage in the neck. This is avoided by maintaining the grip of death and using the tip of your index finger to guide the bougie. Do not expect to see the membrane. In most cases, this is a procedure performed in a pool of blood and guided by palpation. Feed the 6 millimeter endotracheal tube over the bougie and into the trachea. In most adults, 10 to 14 centimeters will be adequate. I'm now removing the bougie. Inflate the balloon. Confirm with end-tidal CO2. And in some cases, if a patient is in a cardiac arrest, confirming with an esophageal detector device. You then secure the tube as usual. The keys to success are: anticipate the need for a surgical airway and do a double setup. Have all equipment ready and laid out before you cut the neck. And remember that unlike cadavers, live humans bleed, and many have big fat necks. Therefore, this is a procedure guided by palpation and performed in a pool of blood. Remember, always keep your finger or an instrument in the hole.